So this is the program which you have on the desk. I'll just move on and talk a little bit about what we've been doing. And I have two quite large areas we've been studying. One is the diagnostic tests and some genetics, which I'm not going to talk about today. Some of you will have been involved in that study, which has taken rather a long time to analyze. It's all analyzed now, it's being written up. And we're very excited about some of the laboratory work which came from biopsies that patients donated. And Jill Norman at the back, Surya Rayurapedi, is one of the students, and David Abraham is going to speak later about doing work in the laboratory. They've been really important and instrumental in making sure the science was good and in coming up with a lot of the ideas which helped us produce some of this data I'm going to show you at the end of this talk. So you know this, and it's what I tell people when I'm speaking about it. There's a recent editorial written in the British Journal, someone called Parvez Hussain from Southampton called it an evil curse, and it's been called, this is pemphigoid, and scarring conjunctivitis in general and pemphigoid in particular as being the most common cause in countries where trachoma is no longer present. So all the developed countries, pemphigoid is the commonest cause of scarring conjunctivitis. And as you know, the management's really complex, not helped by it being a multi-system disease, and the outcomes are still pretty poor. So 30% of patients will lose vision in one eye at some time. And it's easy to make the diagnosis, although most of you, we know from a survey we did that I think the median time to diagnosis was 2.5 years. This is for eye disease. If you present with oral disease, I think it speeds everything up. But for patients, one in five of our patients has eye disease only, and it really is quite a job to diagnose because it's unless it's really bad, the diagnosis is often delayed. And it's been up to 10 years for some patients. And there are a whole lot of other immunobullous disorders like bullous pemphigoid, linear IgA disease, but those usually present with skin changes first, and when the eyes get involved, it's easier to actually get an eye diagnosis. But with mucous membrane pemphigoid, you've got 1 in 5 patients who come with eye disease only, and that's produced really quite a diagnostic dilemma. So if you only have conjunctival scarring, it's very easy to miss in the early stages, and we have to differentiate mucous membrane pemphigoid from a whole heap of other causes of scarring eye disease. There are actually about 25 in the list that I put up for lectures. And this is why you've been asked to have biopsies done at diagnosis, or you should have been. And we do 2 different types of tests which are specific for mucous membrane pemphigoid. If the eye only is involved, they're positive about half the time. And that's quite a big issue for us. And it's something that we're addressing in some of the other studies we're doing. Indirect immunofluorescence, I think I've got a cartoon up here, is when we just take the blood and we look to see if there are antibodies in the blood. So the disease this is a cross-section of an epithelium. This is actually conjunctival epithelium, so this is epithelium here. This is the basement membrane, and this is it's called the substantia propria, it's the tissue underneath. And with these pemphigoid diseases, of which conditions like linear IgA are others, the disease is all directed, the immune response is all directed at this very small bit of tissue here, the basement membrane. And this is a cartoon of this whole area. So you've got epithelial cells here, and you've got basement membrane here, and the disease is triggered by antibodies being directed against proteins which are holding the skin cells to the deeper tissue. And these are the anchors. And the one which is most often involved is this long molecule, BP180. And other molecules may also be involved in this anchoring process. And when you cut through the tissue, if we have to do that sometimes for cataract surgery, I actually should have put a picture in because I've got some good ones now. Everything underneath is completely normal. So all the damage is confined to a really, just to the very surface layer of tissue, and underneath everything's fine. but it can be extraordinarily damaging. And the direct immunofluorescence is when we incubate your tissue with antibodies which are attached to a fluorescent molecule, and they're incubated with a rabbit antibody, which is anti-human IgG and IgA, which are the two things we're looking for. I don't need to go into that detail. But that's what we do with the biopsy for diagnostic purposes. And then with the blood that we take, the serum's incubated with a whole variety of tissues, and the most commonly used is salt split skin. If you use very concentrated salt solution, the skin will split at the basement membrane level. That's this level, and along this here, this is the lamina lucida, it splits here, and that exposes these proteins, and then we can incubate this tissue with your serum from the blood and see if you have antibodies directed at these tissues. But that's positive in only about 20-30% of patients, although we've got some quite exciting data using a new target, which I think has boosted that up to about 70%, but I'm not going to talk about that today. And there are commercially available tests where we can look for antibodies, which are now just being introduced, actually. Those are new. So it's very easy for us to make the diagnosis if the biopsies are positive. That's gold standard diagnosis. If the biopsy is negative from your tissue, but the blood test is positive, most experts will accept that as a diagnosis, but as a positive diagnosis. But it's a big issue for us and for you when these tests are negative and the eyes only are involved, because the standard of care, as I'll come to in a minute, as you probably all know, is to take drugs by mouth, because steroid drops don't do much for this disease. And if you're an ophthalmologist who's not comfortable with using these drugs, you then have to find someone else to use them. And it's difficult to get rheumatologists and nephrologists, the sort of people we work with, to get interested in this, and particularly if you don't have a confirmed diagnosis, because the drugs are dangerous. So patients often don't get treated promptly enough because of concern about have they got the disease or not. And it's okay if you come to a specialist center where we know that half the patients have negative tests, and we're prepared to make the diagnosis having excluded all the other conditions. So what I recommend is that the patients have got to be shown to have, or people who've got this, to have progressive scarring, but you've got to exclude, that's just a few of the other causes. Those have to be excluded, and then you can make the diagnosis. And if the disease is bad enough, then you get on and treat it, accepting that the tests are negative. And this is what we see in the very early stages. There's a little fold in the corner of the eye here, which should be present, and it's lacking there. That's one of the very earliest signs of disease. This is quite early. You turn over the upper lid and you get that white stuff is scarring just under the epithelium at the basement membrane, which is that very sort of just a few microns, 50 microns thick. The whole epithelium is only 50 microns thick. There are 1,000 microns in a millimeter. I think that's right, isn't it? So just to put it in context, this disease is really focused on these surface tissues. And then it's easier to make the diagnosis when the tissue behind the lower lid starts to scar up, and it's not missed once this happens, which is further down the line, and the eyelids will turn in, not in all patients, but in quite a few. And when things get really bad, particularly when the inflammation's been bad, the skin over the cornea becomes opaque, and that's when people lose their sight. And the eye gets dry and uncomfortable. And one of the things I flag up here is that surface tumors can mimic this. So particularly in one-sided disease, usually the tumors are one-sided, not always. That's one case affecting both sides. So it's important to make sure that patients don't have a tumor if they've got one-sided disease. That's actually quite an uncommon scenario, but I put this up for ophthalmologists because it's really important not to make a mistake and start treating these people with the tumors with immunosuppressants, because they get a bit worse. So this is how, you can tell me, this is how the disease progresses. You've got immune-mediated inflammation, which is what I described right in the epithelium at the basement membrane, and that in itself causes surface pain. A lot of inflammatory mediators are released into the tear film, and the eyes get uncomfortable, and those mediators will actually damage the surface of the eye as well. So you get this, you've seen us ophthalmologists making little spots on the pictures of the cornea, and that's what we call punctate keratopathy, which blurs your vision and causes discomfort. And if the inflammation is really severe, and that's about 10% of the new patients who come to me, the skin-making cells on the cornea, which should be clear, stop functioning, they get damaged by the inflammation, and the tissue of the conjunctiva, which is the white part of the eye, which is opaque, grows over the cornea to take the place of the corneal skin, and that leads to corneal blindness. That's an uncommon problem, but I probably see a new case like that every 1 or 2 years. More often than that, 1 to 2 a year. The inflammation drives the conjunctival scarring, at least initially. And that causes the eyelids to turn in with the lashes, which scratch the surface of the eye, and that can lead to infection and a lot of discomfort. That also leads to the surface pain that I know that you have had to undergo. If it gets bad, the lids don't blink properly, which causes more problems because the cornea doesn't like to be dry. And also the scarring, fortunately relatively late in this disease, will scar up the little ductules which take the tears from the tear gland, which is unaffected, into the eye, causing a dry eye. In another scarring disorder called Stevens-Johnson syndrome, that occurs right at the beginning, and so people have a dreadfully dry eye right from the very start. And those things all lead to surface disease, which is the sort of ballpark term for everything which affects the skin on the surface of the eye. And we get ulcers which don't heal, these little spots of damaged skin which affect the vision and predispose to infection. Infection can be usually devastating, and blood vessels will grow over the cornea, which doesn't help the vision, and the cornea scars as a result of the ulcers and infection, another route to corneal blindness, and all of that causes a lot of pain. Does that sort of sum up what you think you've been through? I put that together for a recent lecture. It's rather better than what I was trying to do before. So there are a lot of studies now showing that steroid drops, they do help the inflammation a bit in some patients. So we do use them, but and there's been no trial done of steroid drops, but it's been widely accepted that systemic treatment is the standard of care. Now, not everybody needs treatment with oral immunosuppressants, and some of you may not be on them, and about 1 in 5 of my patients they aren't bad enough to need that. The disease is going so slowly that they're never going to get into any real problems, but 80% usually require treatment with one of the drugs I'll go through in a minute to control the disease. And this is a big problem because although we can control the inflammation in 90%, it takes several months to do that. Usually 3 to 4 months to get the inflammation under control in the patients for whom it works, and there are a lot of side effects, as you all know. We've had to change treatment. We reviewed 112 patients some years ago, some of whom we'd been following for 10 years, and 30% of those needed to have the drugs changed because of side effects, which were intolerable or dangerous. And also, the scarring continues in 50% of those patients, and there are several studies from myself, Cy Ross in Birmingham, and the Americans, showing that the scarring continues to progress even once you've got inflammation control clinically. The eyes look white and the scarring just continues. So you've had lid surgery to get your entropion sorted out, and then it recurs 5 years later. So we've had no treatment for scarring control. There's no effective antifibrotic therapy. And this is what used to happen. This is from my predecessor here really in this area, Peter Wright, who I worked with for a long time. And we hardly used, immunosuppression only came in when I started as a consultant here for this disease. And this was a patient who had cataract surgery, and this is 3 or 4 years later with surface failure. This is a very bad case, one of mine. And this is with cyclophosphamide, and we've got the eye. There's been a lot of scarring here, and you can see that this is the same eye. There was no scar tissue here, but in the time it took to get this under control, that's developed. But he's still seeing well. So this is what we do for patients with really bad disease, and some of you will have been through this. So if you come with a really red inflamed eye, and we're sure that the disease is due to mucous membrane pemphigoid once we sorted out the diagnosis, and I can do that sometimes the same morning. If they're really bad, I'll just get on and start all this. We start a high dose of oral prednisolone. Prednisolone by mouth has a lot of side effects. It's worse than any of the other drugs, and there are studies way back showing that you can't control the disease in the long term with oral steroids, so you shouldn't be on them for a long time. And I don't use them once I've got things under control, even at low doses. So we always start steroid with a steroid-sparing agent. Cyclophosphamide is the drug with the best track record, and if that isn't working, we've been going to rituximab. And I've contacted, I think, 2 or 3 of you recently. We always used to get the rituximab applications approved, and that went through the local services, what's it called, the IFR, individual funding request form, which was, they have a committee in each area, and that's now all been taken over by NHS England, who are refusing to agree to any of this. There's a sort of blanket refusal. You fill out a huge form, different one, send it off, and the Royal National Institute of the Blind is currently running a campaign, as we are. It's a complete mess at present. So this is not available. Intravenous immunoglobulin costs $27,000 a year. Rituximab's about $3,000 or $4,000 a year. And currently, we should be able to use intravenous immunoglobulin in patients who can't get rituximab. I've gone on for too long here, so I'm just going to whip through this. Once, we can only use cyclophosphamide for a limited period of time, 12 to 14 months, because you start to run a risk of bladder cancer after that. And rituximab, we usually give 2 cycles. And then I introduce dapsone. Before, you can use dapsone with these drugs. That's safe to use. It's an old-fashioned antibiotic. It's about 70% effective. And if that isn't controlling the disease, once you've withdrawn cyclophosphamide rituximab, I'll add in mycophenolate or azathioprine, or use those as soon as the cyclophosphamide is stopped. If patients have mild disease, we start at the bottom here with dapsone and sulfapyridine. Sulfapyridine I only use for patients who don't tolerate dapsone. If that isn't working, we go to mycophenolate and azathioprine. If that isn't working, we go up to cyclophosphamide and go back up that way. Methotrexate, there's only one study from Australia. Colleagues I know quite well. I don't think it's very effective, so I don't use it much. So this is what you can achieve pre-treatment, post-treatment, but the scarring has progressed. And this is a man who still comes to the clinic. So that's 4 months later. You can see how much scarring. That's the same eye. And this patient, 2006 to 9, he's developed that symblepharon here, despite the fact he's been well controlled really all this time. It hasn't caused a problem. But this is just a good example of a patient's eye showing that this scarring just does go on. Now, very briefly, I'm going to finish up with what's actually 6 years' work, I think. And I think it's about 7 different groups of experiments that were done with David, Jill, Julie Daniels, and Sarah Dale, and also Surya in the audience. And we found out that aldehyde dehydrogenase, but this is by doing gene expression studies, was it was present in the diseased tissues, both in the fibroblasts, which are the scarring cells we grew out of tissue from patients, and we also have a new mouse model. And I won't go through all the details, but there were actually relatively few targets that we found when we looked with this gene expression study. And so we focused, this was already David's input, we focused on aldehyde dehydrogenase because that has a role in scarring in other tissues. And we found that one of the inhibitors of this, which is antabuse, it's used for alcohol abuse control, and that's a drug that's available. When we used that, we could restore the abnormal scarring cells, which in about 5 different assays behave very abnormally and continue to do so after they've been removed from the human tissue. So once they're switched on, they don't appear to go back. They don't go back to normal. We could normalize them by putting in this tiny amounts of this inhibitor, and also in the mouse model, which is new. It's not a pemphigoid, but it's it's triggered by having a severe inflammatory response in the conjunctiva. It looks like pemphigoid, And it behaves like it because we could drop that into the mouse after we've stimulated the inflammatory response and switch off the scarring in the mouse. Very exciting. So we're planning to take that forwards for, we failed to get a large welcome grant, but we're going about to put in another one. I think we'll get this funded because we didn't have all the background work. I won't go through all this now because there's not enough time, but this just shows that, where are we? This is probably easy to see. This shows control tissue, and the brown stain is aldehyde dehydrogenase. So both in uninflamed and inflamed pemphigoid, you've got a lot more brown staining. This is something called flow cytometry, and we could show that the ALDH was both active and present in the disease compared to the control tissue here. And this is present in the fibroblast as well. These are some of the studies we've done using these assays to show that these cells behave, can be switched off and behave normally if we inhibit the ALDH. And then if we give the cells normal cells, retinoic acid, which is what is manufactured by ALDH, we can switch the normal cells and make them abnormal in these assays. It was really quite impressive findings. And this is the mouse, which is ovalbumin induced. You give unfortunately mouse an injection in its peritoneal cavity, and then 2 weeks later put ovalbumin eye drops in, and the mouse gets a very inflamed eye. And we can show that we could, this blue stuff here, this MSB stain stains fibrous tissue, and this is the untreated mouse. This is where it's been treated with ovalbumin with a lot of inflammation. It's got a lot more tissue, and this is with ovalbumin and disulfiram, which inhibits the scarring and also actually inhibits the inflammation. So it has an anti-inflammatory effect, and it's being used for that. An American company is developing it for that in another area, but not for scarring. So I think I've run to time. So that's some of the most exciting work we've been doing recently. We think we may have, we're looking, if this works out the way it appears to in the mouse, it's called an irreversible inhibitor, and we're looking at 1 drop a day. And I say it's already being used in the States, but they won't play with us. I contacted the company, and they don't want to have anything to do with us at the moment. And we've done a lot of work. There are, I think this is 38 original studies over the years and 9 book chapters. And you'll see some of the speakers today up here, but there's a lot of people over the last, it's 25 years since we started working in this area. And I must say I'm very proud of what we've been able to achieve recently. Okay, any questions on that? Isabel?
How would you know whether the scarring is occurring?
Well, we've got sort of, there are several methods of scoring the scarring, and I've tried to introduce those into the clinic, but the tools we use for measuring it they're quite, well, they get lost and they're not that difficult to use. So I've now got a separate clinic going in the afternoon where we've got more time. And for patients where I'm worried about disease progression, then we can see them on a yearly basis there. If there are gross changes which occur, in effect, if you don't have much inflammation, the scarring process is slow, but it does progress. So it's driven more by inflammation. We can't get everybody controlled. So for patients with eyes that are free of inflammation, it's not normally a bother. It can cause problems, and if we could inhibit that, that would be great. But the bigger problems are for people who've got a low level of inflammation. And when I said the scarring progresses in 50% of patients, that's with clinical inflammation control. But we know from other studies done actually before this last run of studies that we don't get biological control of inflammation, because if you look at markers in the tissue of patients who are apparently controlled, they're always elevated. They have been in our studies. So that the drugs that we're using to control inflammation doesn't switch it off completely. So that's another problem, but it's a good question.